Hi guys, me again. I'm doing a reflection for ANP 8008 and I'm wanting to talk about my 22-year-old that was brought in with concerns of sedation levels with partner via the ambulance. So this one was an interesting learning one for me. I had to liaise with both the police, the clinician on call and other family members that were quite concerned. In the community, her GCS was sitting at 8, and I will talk through this case. So I had a 22-year-old who had a history of the presenting complaint of having trouble walking around at about 11 o'clock at night. She had had 5 tequila shots and 2 Jack Daniel shots. And she'd come down from Melbourne to celebrate her partner's birthday at our pub. The amount of alcohol was stated as a normal intake for her, and she was unusually out of it. They questioned if the drinks had been spiked with GHB, a substance I had previously been not overly familiar with. I know it is a party drug and also a drug that they use to assault women and men with, but we haven't had a lot of presentations like this, so, and I was the nurse in charge. The patient had reportedly vomited 40 minutes before presenting, and then had a sleep at home while the ambulance were called, and the partner in the ambulance couldn't arouse her from her sleep when they arrived. So she was withdrawing to painful stimuli, according to AV, but she had nil signs of trauma or any other injuries. She denied, or the partner had denied, any other symptoms or known COVID exposures. That is something we write in for all of our cases, and we have done since the COVID-19 epidemic, so that's neither here nor there. And everyone follows the correct PPE management in our departments. The partner was let in for this particular case because of the caring nature of the relationship, and he was her support person and she did need that. Okay, so we went through a primary survey straight off after the handover, and I could see that her airway was patent, you know, her breathing was regular. She had no shortness of breath, but she was speaking in words because of her confusion. Her circulation showed that she was warm. She had dry skin with no sweating, with a CAT refill of 2 seconds, but she was really pale. She was alert to voice. She was rousing to voice, and she denied having pain when asked. Past medical histories of PTSD. She had a seizure 6 months ago due to anxiety and was hospitalised for this. She had no other named past medical history, and this was given to us by her partner and fiance, I believe. The social history is she lives in a share house and she actually works in aged care, and she's a regular THC consumer and drinks socially to this number about once or twice a week. Medications. 1 week ago, she swapped the oral contraceptive pill from an implant. No other medications noted. She had nil known allergies. On examination, her CNS, once she got into the department, showed a GCS of 14 with E3V5M6, Pearl equal 3+, right and left. She had good strength in her arms and legs. She hopped off the stretcher and decided she needed to go to the toilet, which I initially was quite hesitant about, but I assisted her into that, and she did have a reduced coordination, but she denied any numbness or loss of strength. She was orientated to time, place and person, which was interesting. She knew where she was. She knew that she was at the hospital. She looked over at the clock and used it as a prompt to tell us what time it was. She had reported no loss of consciousness. She said, oh no, I just went to sleep. And she could actually remember the whole event, which was validated by her partner. Her CVS system showed a low blood pressure of 103/69. Heart rate was 99 to 105, so she was a little bit tacky. She had really pale skin. Her ECG showed sinus rhythm, but she had a change in lead 4, which I took a photo of, and I asked for a clinical review straight away. So I sent that through to our clinician on call and told the clinician on call that I'd like them to come and review this patient. Circling back, her GCS by this time had gone up to 15. She was definitely more rousable, and became more alert. Respiratory wise, her chest sounded clear, her sats were 100%, her resp rate was 18. Metabolic, I checked her sugars and her blood sugar level was sitting at 5, which is a fairly reasonable sugar for someone that hadn't eaten much. She was only a very slight of build, so she was 51.9 kilos, so I did get her to jump on the scales. She had no issues with appetite or bowels. In fact, she said she was hungry. And for renal, I did a urine test to detect any signs of infection or any other abnormalities, which came back with no changes. So I also checked for beta HCG because of the change in contraceptive and because of her age, which she came back as negative with as well. So she started to become stressed about being in hospital as soon as she started to wake up, and said she felt fine now. Her partner was trying to reassure her that we needed to be in hospital. I had the clinician called as she was coming in still, and the plan was to give this patient ondansetron 4 milligrams sublingually, and to give a litre of normal saline over 2 hours and to monitor her. The patient accepted the sublingual medication but refused to stay in hospital. So I explained the risk of discharge to this patient, and the patient still decided she would prefer to leave and sign the discharge at own risk form. I did explain to her that this could result in her dying if something happened, and that she came into hospital because she wasn't able to be woken up. However, the patient still decided she really wanted to go home. She had a high level of anxiety. She was very grateful for our help, but being in hospital was very stressful for her. Even if we used all of our de-escalation techniques that were seen in the PCCM, we turned the lights down. We said, oh, you know, your fiance can hop in and you can just have a little sleep here while we do this. It's not a big deal. But she was really adamant that she wanted to go, so she was displaying those behaviours, but she was still reasonable. And the partner was going to remain with her overnight, and they were responsible adult, and he was happy to call an ambulance if there was any other further concerns. Because they were walking home, I actually got them to send me a text message on my phone to let me know that they had got home, and I also made plans to get her to follow up with the GP the next day. They did send me a text message, which I made a little note of, that they were home, they were safe. And then the next day, I got a phone call when I woke up from my sleep saying that the police would like to have that urine tested, which is an interesting situation. I haven't had that before. We don't have any forensic nurses on staff, So when it's a forensic issue, usually we have the police send down somebody, so there's no chain of evidence broken. So my notes were subpoenaed to the case because there was a case made by the patient with the police station, and I've agreed to speak if anything further is needed from me. So for me, that was a really good learning point. I did a little bit more research into my discharge against own risk, and I found out that in my notes I need to be more specific about what I actually detailed the risk might be. I wrote, explain risk of discharge to patient, and patient decided she would prefer to leave and sign the discharge against medical advice. However, what I should have done is I should have listed what was explained and been a little bit more clear on that. So next time I do have a little bit more information to improve my practice, which is really important to me. And I still feel like the care that was given to this lady was really appropriate and really safe and comfortable. And not everybody wants to stay. And I can appreciate that. Not everyone wants the plan that our clinicians want for them. And I did try and give the information so she would understand the benefit to staying. But you know what? That's how it is sometimes. All right, thanks.